We are live, so yeah, we can start.
Hello there, hi, and good afternoon. My name's Leanne Go, I'm one of the allergy consultants. So, yeah. Hello. Okay,
hello there, hi, and good afternoon. My name's Leanne Go, I'm one of the allergy consultants.
Yeah, there's a bit of a delay going on, sorry. So,
hello there, hi.
Just to introduce our team, myself, Dr. Leanne Go, and Penny Salt are allergy consultants at University College London Hospital. With us, we also have two other members of our team, Lakshmi Singaram Chetia, one of our specialist nurses, as well as SOPHIA KALLIS, who is our allergy specialist dietitian. And today we're going to teach you about how to help your patient manage both their skin and respiratory allergies. So to start off with, we're going to have Dr. Salt going through what basic eczema skin care is. I will then take over and go through how you manage eczema flares. We'll give you all a little bit of a 10-minute comfort break to get yourself a cup of tea. And then we'll come back to have SOPHIA going through dietary considerations when you're managing patients with eczema. And Lakshmi will then go through the use of inhalers, nasal sprays to help manage your patient's asthma and allergic rhinitis. Okay, so I'm going to hand over now to Dr. Penny Salt.
Hi, I'm just checking with the rest of the team that they can see the screen.
Yeah, good, Penny.
Okay, good. Okay, that's great. Hi. So what is eczema? So eczema is primarily a disease of the skin. Our function of our skin is to act as a barrier to help retain moisture and prevent antigens from entering the body. Although we don't clearly understand the cause of eczema, there are multiple factors that do contribute, including genetic and environmental factors. So things that play a role are things like skin barrier defects, pro-inflammatory predisposition, anomalies in the microbiome, and environmental influences. There's often a family history among parents and siblings indicating a genetic predisposition. And a couple of genetic abnormalities have been discovered associated with eczema, and one of these is filaggrin deficiency. So filaggrin is a protein that binds keratin fibers in the epithelial cells, and without it, the corneum stratum is damaged, exposing the epidermis to allergens. It's responsible for creating the skin barrier that retains moisture within the skin. And without it, the skin becomes a leaky skin barrier, which makes the underlying structures more vulnerable and unable to retain moisture. This picture shown is one of my patients who has a filaggrin deficiency. The evidence of filaggrin deficiency is the increased linear markings over the hyperthenar eminence over here. 40% of patients with severe atopic dermatitis have been found to be filaggrin deficient. There are other mutations also linked with problems in barrier proteins. Okay, so the diagnosis of eczema is a clinical one. It's very common in children and often starts under 1 year of age. It causes dryness, itchy skin, redness, cracked skin, excoriation, inflammation, and over time the skin becomes thickened, and there may be areas of hypo and hyperpigmentation, which is more common and obvious to see in dark skin patients. The changes do wax and wane over time. In younger infants, it commonly affects the cheeks, scalp, around the neck, and the limbs, and in older children is mainly affecting the skin creases. The disease may vary from there's a very wide spectrum of disease and may vary from just very mild skin changes to more extensive skin changes with constant itching, excoriation, and possible skin infections. There's different kinds of presentations of eczema. So for example, this is discoid eczema, where these very circumscribed patches, which look very much and need to be distinguished from tinea capitis, to this papular version, which is a more common presentation of a papular, intensely itchy rash in more dark-skinned patients. The effect of eczema on a patient's life is very variable, to annoying intermittent itch, to constant itching and severe effects on quality of life. For severe patients, they are having to apply creams multiple times a day. They're constantly itchy, they may be in pain, they're having to deal with constant infections. It may affect their sleep, their activities, poor concentration, and affecting their schoolwork, affecting their self-confidence. We know that quality of life scores in these patients can be worse than those seen in patients and families with type 1 diabetes. So the management is really looking at a variety of different angles. The one is to try and avoid any known triggers. The mainstay of care is basic skin treatment and management of flares, which my colleague Dr. Go is going to go on to and discuss in the next talk. Okay, so there's a wide variety of triggers that have been identified in making eczema worse. So perfume products, soaps and detergents, synthetic fibers and wool on direct contact on the skin, washing powders and fabric softeners, potentially a whole variety of common food allergens that my colleague SOPHIA KALLIS will also discuss later on. Changes in the environment and weather. Overheating is a very common one, and in homes in the UK where we have central heating and our homes become very warm and cozy at night, this is a problem. Exposure to house dust mite or cat or dog dander, exposure to tree or grass pollen, and mold. These are all things that can contribute. And if you identify this as being a trigger, a potential trigger for your patients, to try and minimize these is advised. We always advise cotton clothing, avoid detergents and use non-biologic washing powders, and to not use any of these fragranced products on children's skin with eczema. Okay. So our basic skincare, the mainstay of treatment is to use emollients on the skin. It's really important to explain to your patients that we do not have a cure for eczema. Basically, this is managing the skin on a daily basis and then addressing flares as needed. A lot of eczema does improve as children get older, but I think it's really important to manage patients' expectations at the initial consultation. And it's always worthwhile spending a bit of time explaining this when you see a patient for the first time. The role of topical emollients is to try and reduce water loss and to try and cover it with a protective film to try and repair the damage that's been done onto the top layer of the skin. So by preventing dryness on the skin, you can also hopefully prevent it from becoming itchy, because unfortunately what happens in eczema is there's this whole itch scratch cycle where you have dry skin, you start to itch, you scratch, the skin barrier becomes even more compromised, irritants and allergens can enter the skin, inflammation sets up, and you set up this whole cycle. So what we want to try and do with these patients is try and break that itch scratch cycle. And there's a variety of ways of doing that. So these are scratch sleeves, which you can buy for children to wear. In younger children, you can use mittens, keep their nails short, and try and teach children from an early age that when their skin is itchy, not to scratch, but for reach for an emollient and put that on to try and prevent that from happening. You may want to turn and use antihistamines as a nighttime sedative or an anti-inflammatory to an anti-allergic to try and prevent scratching at night, but you probably only want to try these for a short period of time. If the skin is itchy, apply more emollients. Okay, so which moisturizer? So there are hundreds of emollients available on the market, and they vary in the amount of water content. So this is an ointment. It's got the least amount of water in it. It's the most greasy. It's probably the most unpleasant one to wear because it's hot and it's greasy and it's thick, but it's the most effective because of the high oil content. It stays on the skin and lasts for longer, and so for particularly dry skins it's useful, and also if you are you don't have to apply it as often. On the other side, we have lotions and gels, which have the highest amounts of water content. They have the lowest oil content. They are the least effective, but probably the most comfortable to wear. And a cream is somewhere in the middle. You may use a combination of these creams. So on different parts of the body, you use different, either an ointment or a gel, for example. So you might want to use a gel on your face and use an ointment on your body, or you might just vary what you're using at different times of the day. So at nighttime before going to bed, you're applying an ointment, whereas during the day, you're wearing something lighter. Or it may be that you find that in the winter it's more comfortable and more acceptable to have an ointment, but during the summer when it's hot, you may want to wear something on your skin that's a bit lighter. I've put in this cream. It's called Episerum, and it's a new cream, and it's basically what's called a trilipid. If you just hold on 1 second, it's a combination. It's a combination cream that contains ceramides, cholesterol, and free fatty acids, and it's got a pH of 5. And that has been found to be very useful in a study called the Pebble study, which was a study done in Melbourne in 2019, which looked at infants at high risk of developing eczema and randomized them into using Episerum cream from 3 weeks of age for 6 months, or using and the other group was basically they could apply any creams that they wanted. About 30% applied a cream 3 times a day, and in these other high-risk infants, no creams were applied. And the outcome was to see if you could reduce the incidence of eczema from developing, and also whether you could reduce the onset of sensitization to foods. The study did show a trend to reduce atopic eczema, but it did show a significant reduction in food sensitization at 12 months. So it was a real success story. This cream is not widely available, and when I try to look for it, it has to be ordered via the Episerum website. But I think this is quite exciting. That actually there might be a cream that might work quite well in the long term at helping to reduce or prevent patients from getting eczema and potentially reduce food allergies. Okay, so how to apply. So it's really important that patients are using sufficient numbers of a sufficient amount of cream on their skin. And this picture demonstrates really nicely sort of the depth and thickness of emollient you want to apply. It needs to be applied in the direction of the hair follicles to prevent folliculitis from developing. And it needs to be applied regularly. So it's useful to actually think about a clock and point out to patients how often they need to be applying their creams. The more dry your skin is, the more often you need to apply the cream. And make sure that when you're prescribing that you prescribe enough cream to last the patient for the month. So creams often come in, emollients come in different sizes, 500 ml, and yet sometimes they can also be prescribed in smaller tubes. The smaller tubes are useful for patients to be able to take them along to their workplace or to school. Otherwise, you can get them to dispense their larger creams or ointments into smaller containers to take with them. Just to remember that if you're using an ointment, to use a spatula or a spoon to take the ointment out of the tub rather than using your fingers to prevent the ointment from being contaminated with bacteria from your fingers. So wet wrapping is another way of applying and keeping emollients on the skin. This is just basically simply talks through how to use it. So you wet the wraps, you do have your normal bathing routine. Afterwards, you apply the cream and you then apply the wet wraps directly to the skin and cover with a layer of clothing. There are different brands that actually make these types of clothing. This is Comfy Fast, and there's another company called Dermasilk, or as you can see here, you can actually make them yourself by tying tubey grip together to make garments that sit close to the skin, and this helps to prevent itching. And in severe cases, you can also apply topical steroids under these, but I'll let Leanne talk further about management of flares. So bathing is an important part of eczema care. We would advise that patients bath every day. Bathing is superior to showering, and that's because you're able to soak in the water for longer. A lot of patients complain that the water can be burning to the skin. We would always advocate applying a moisturizer to dry skin before bathing, and then to use a soft flannel to wash the skin. You want to prevent any rubbing or irritation to the skin, and not to make sure the water is not neither too hot or too cold. There are a huge amount of bath additives to add to the water. However, there was quite a large review of the data which didn't show any benefit to using emollients, bath additives, apart from making the bath very slippery for the next person who gets in. And so we don't use bath additives. To keep it very simple, you can apply whatever moisturizer or emollient the patient is currently using. That can be used as a soap substitute. If patients are having lots of skin infections, then Dermal 500 is useful because it contains an antibacterial antiseptic. For patients who are having regular skin infections, you may consider bleach bathing. So that sounds quite dramatic, but essentially it's about as chlorinated as a swimming pool. You can use something quite straightforward and something that's available like Milton. We would advocate half a cup full for a full bath, or a quarter cup in a half bath and in a half size tub. Be careful not to use that the child shouldn't put their head under the water. So it's really useful for bathing of the body, but not of the head. If you are using shampoo and the shampoo is irritant to the skin, then you can always wash hair over a basin. There are a wide variety of products for the hair, but you can actually just use the emollient that you're using to keep it simple. And then there are, for worse involvement of the skin and on the scalp, there are some medicated shampoos to use, coal tar like T-gel, ketoconazole if there's fungal infection, and also there are a wide range of steroid shampoos that you can use as well. So swimming and sunscreen. So just because you've got eczema doesn't mean you can't swim. So we would advocate applying a moisturizer an hour before swimming, and after swimming, rinsing off straight away and then reapplying your moisturizer. Some children find that the chlorinated pool is almost like having a bleach bath and it makes their skin better. Some children find that actually it is quite irritant, in which case you might look for a swimming pool that has non-chlorinated pool. And likewise, some people find that salt and swimming in the sea is helpful and others find that irritant. So it really just depends on your patient. Sunscreens can actually sometimes be a bit difficult because they can be quite irritant to the skin. As a general rule, chemical sunscreens are worse than the mineral ones, the ones that contain zinc. So this kind of white type of sunscreen that you see surfers use, this is a zinc-based. They're often better tolerated. Sunscreens tend to get activated in the sun, and so sometimes you don't know until the child goes out in the sun, and sometimes it can just be trial and error to find the right one. If the skin is very sensitive and there isn't a suitable one, then just to remember safe sun exposure, keeping covered up, keeping the head covered, staying out of the sun in the hot times of the day, and staying in the shade. So there are a couple of cautions just to remember that emollients are extremely flammable, and especially when patients are having recurrent applications, their bedding and their clothing also becomes saturated. And so the advice really is to avoid smoking around these kind of creams. And if your child has severe eczema, advise parents to be very careful about that, and to regularly wash their sheets and their clothing to try and reduce the amounts of paraffin in the sheets and in the clothing. We also would be very careful and advise patients not to use any emollients that contain nuts or coconut, for example, as putting creams that contain food on the skin creates an environment for bacteria to grow, and also may sensitize the patient and can actually cause them to become allergic to that particular food. We'd also be cautious about using herbal remedies, especially when their contents are not disclosed, because they sometimes contain high quantities of steroids and can also contain harmful things like arsenic. So it's always better to choose an emollient where you can actually read the labels, where you can actually see what the ingredients are. There are some creams that are not ideal because they create more dryness rather than retaining moisture. So aqueous cream is quite an old-fashioned cream. It's very reasonable and has been quite widely used in the past, but we wouldn't advocate it as a leave-on moisturizer, okay to use for bathing. And the same, olive oil and sunflower oil are widely recommended by midwives for newborn babies with dry skin, but actually they promote transepidermal water loss, so we wouldn't advocate the use of olive oil or sunflower oil for eczema. And just like managing expectations and explaining to patients what to expect from eczema, it's really important also to spend some time empowering them with information on how to self-manage eczema. And so this is just an example of our allergy plans that we hand out, because it's quite a lot of information that we provide for patients to remind them how to manage their eczema, how to avoid triggers, and I think it's time well spent when you see patients for the first time. Thank you. I'm not sure if we have time for questions now or if there are any questions on the chat, which I'll be happy to answer.
Yes, we have a few minutes for questions, so if anyone would like to pop them on the chat, please do so. Thank you very much, Penny. That was an excellent and really interesting talk. So far, there are no questions at the moment, so maybe what we will do is save, if anyone has any, we'll save them towards the end, just pop them on the chat and we will have a look at them all together. I'll progress now and just talk with about managing flares. Give 1 second to share my screen. Okay, so managing the eczema basic skin regime is absolutely paramount, yet you will see patients coming to you and telling you this cream does not work, my baby's skin is no better, and that's because at the heart of managing the baby's eczema or the child's eczema is actually restoring and nurturing that skin barrier, and that's the basic eczema skincare regime really is effective, and that will prevent you having as many flares. However, once your skin is flared up, and we've got a few examples here, you need to be able to manage the flares using topical steroids. Yeah, topical steroids are the mainstay of managing flares in eczema. There are some other creams that we do use, which I'll come on to later, but in the first instance, we generally reach for them. Now, where and who, what cream would you use really depends on the age of the child. It depends on the site that you're treating. So over here, I've got a young baby, and you're going to start with the very mildest of steroids, something like 1% hydrocortisone, particularly if you're going to use it on this baby's face, because their skin is much thinner and sensitive and steroid naive. So they haven't yet been exposed to any steroids more than likely. Similarly, this young girl, she's got facial eczema, and you can see around her eyes, which are really quite inflamed and sore looking and itchy. You need to use, because that is a sensitive area where the skin is very thin, it will respond to much milder steroids, for example, than on the other end of the slide where you can see this difficult hand eczema, thick lichenified skin around the ankles, which are going to require a much more potent topical steroid to get under control. Other areas to be mindful of are in these intratriginous areas, so under the armpits, in the groin area, are also, because they're under and folded in, there's much more systemic absorption of the topical steroids, and you can get away with using much milder steroid creams. You can think about obvious triggers for this poor lady's eczema flare that's had under her arms, very likely to be due to her underarm deodorant. Okay. And down at the bottom, flexural eczema, sometimes nodular prurigo, where you've got really thickened nodules, and that also particularly requires quite potent steroids, and sometimes we do use them under occlusion, which means putting a bandage or a plaster over it to enhance the absorption. When you cover a topical steroid, and be mindful of where you're putting it, so if you're putting it, for example, in the nappy area, you increase the potency tenfold. Okay, so something like 1% hydrocortisone will then become as potent as Elecon, or what we call mometasone fumarate. Okay, so really important to think about where you're applying the skin and whose skin you're applying it to. As a general rule, you're heading for the lowest possible potency that controls the flare. And you know that's the case if you start seeing improvement after 2-3 days. If you're not seeing any improvement, it's likely that you need to consider a stronger steroid potentially, or perhaps, is there a reason why this patient is not responding, which I'll also come to later, when patients don't respond as you would expect. Okay, so how much do you apply? Over here, this picture shows a fingertip unit, and the fingertip unit does vary with individuals, but will cover approximately the area of 2 palm size. If you look on the internet, you'll find lots of rough guidelines to give you an idea by age and site how many fingertip units on average you need to use. Most of the time we find patients are not using enough of their topical corticosteroid. You can tell that by asking how long the tube is lasting. And this is where size really does matter. We do get patients who have extensive eczema over vast areas of their body, and then you ask them to show you what cream they've got, and they pull out a 30-gram tube of hydrocortisone, which they've had for the last year, and you know absolutely that person is using insufficient quantities of steroids. So the steroid creams do come in smaller sizes, which can be convenient, for smaller areas like the eyelids and so on. However, if you're treating large areas of the body, please prescribe the big 100-gram tubes, because your patient is going to need good quantities in order to manage their skin. Okay, so how do we tell the potency of the steroid? And you know, you'll have steroid creams that you're really very familiar with and others where you're not. And it's really important to inform your patients what is, you know, what to look out for. And you can't rely on lots of the packaging. For example, you've got this package here, which says maximum strength cream. It's 1% hydrocortisone. Over here on the other side, you've got mometasone furoate, which is 0.1%, and then clobetasol propionate, which is 0.05%. Many patients get fooled by packaging that says something like maximum strength. They get fooled by the percentages, and as do healthcare professionals, actually. Clobetasol propionate here, 0.05%, is actually an ultra potent steroid. Mometasone furoate, 0.1%, is a potent steroid, and 1% hydrocortisone cream here is a mild steroid. So always check and look up. There is good guidance on the British Dermatology Society's website on the different potencies of the steroids if you're not sure what your patient is bringing into the clinic with them. Okay. Now coming on to other treatments. So topical corticosteroids are the mainstay of treatment. Sometimes we cannot get our patients down to responsible levels of steroids. Either they're needing very potent steroids for long, or sometimes they're needing steroids constantly for long periods of time. And every time they try to wean down the steroid, the eczema just flares up again. Okay. One strategy is to try and get the patient onto a safe maintenance regime of the steroid, where you apply once daily when the child is flared up. Once the flare is completely settled, you wean to alternate days for 1 week, and then you get them onto a twice weekly maintenance regime. Some people say weekend therapy, where they apply on a Saturday and a Sunday, and other patients will just apply at any other 2 random days of the week that's convenient for them. Now, if you can't get your patient most of the time down to a safe maintenance regime of 2 days per week, most of the time, then you may need to consider some of these helpful steroid sparing agents. So these are topical calcineurin inhibitors. They also come in different strengths. So we've got Elidel cream here, which is pimecrolimus 1%. And this is about the same potency as 1% hydrocortisone equivalent. Okay. Protopic comes in 2 strengths, 0.1, which is the stronger, and 0.03, which is the weaker. And so 0.1 would be equivalent of a potent steroid, and 0.03 would come as the equivalent of a medium strength potency steroid. Patients are often quite anxious. If they Google these treatments, they can find scary stories of cancer warnings. Tacrolimus historically was used as a anti-rejection treatment for organ transplants, which you're taking very high doses into your systemically, orally, and that comes with a definite risk of malignancy and infection. Using Protopic topically, we do not see that same effect. Bearing in mind, we have got about 25, 30 years of experience using these treatments, as opposed to more than like 100 years experience using steroid treatments. But still, we consider them safe, and they're a good interim measure, because the next step, if your patient really cannot get down onto safe levels of steroid or get no control of their skin at all, we need to consider systemic treatments, which, as you know, come with actual risks that we described before. So they're a really good in-between step, and the patient may not need it for a long period of time, because, like as Penny described, if you manage to break that itch scratch cycle, often the patient with time, after some settled skin for a few months, will be able to wean down and step down on their treatment. So you must always actively manage eczema. Step up if you're not in control, and step down when you're not, when you finally get control, to the minimum amount of treatment necessary to control the skin. Now, Protopic does have some side effects. When you apply it even to normal skin, you get a slight burning effect. This does improve with use, so warn your patients about this, and tell them to expect it, and that it will improve with time. It's helpful if you actually settle down the inflammation with steroids, and sometimes you need to use quite strong topical steroids to get this the the skin settled before you can actually apply the protopic, because broken down and flared up skin gives that more burning sensation than healed skin. Okay. So preparation is the key, yeah? So steroids and protopic come in different preparations. They come in creams, ointments for the calcineurin inhibitors, and steroid come in an even wider range of formulations, which also include gels, scalp application, as well as sprays. So where would you use which preparation? A lot of it is down to what the patient prefers. Just like when choosing an emollient, you don't prescribe the one you think is best. You prescribe the one your patient likes to use, because then they will actually use it and get better. As a general rule, ointments are quite good where you've got very, very dry skin. Yeah, they're not good if you've got very weeping and wet and oozing eczema. It's actually better to use a cream in that circumstance. Gels are really helpful for managing scalp eczema. They're also specific scalp applications, which are much more pleasant to apply into your hair. Yeah. Also, I have some patients who have autistic spectrum disorder who really do not tolerate anything sticky due to their sensory issues on their skin, and they tolerate these gel or liquid preparations a lot better. Whilst they may not be ideal, at least you're able to apply something to the patient to try and help their skin. The sprays are really helpful. We have a big, large diabetes service at UCLH as well, and our patients are using the Dexcom glucose continual monitor sometimes get eczema, dermatitis to the adhesive on the patch that they're wearing. And so if you were to apply an ointment or cream, you would not be able to then apply the adhesive on top. So we pre-prepare the skin with some of these spray applications that are available and really helpful. Okay, so preparation, always think about what you're prescribing rather than just the strength of what you're prescribing. Okay, so you've done all you can, you've followed all the advice, you've stepped up, the patient's still not getting better, still itchy, not responding. And even worse still, I mean, this worked before, but it's not working now. And what's the commonest reason? The commonest reason, provided your patient is, of course, using the treatments and complying and following your advice, is that there's an underlying infection of the skin. Now, in eczema, particularly where you're using steroids, particularly where you're using topical calcineurin inhibitors, you may not get these really obvious signs of skin infection, which we're all used to as pediatricians. You may not see this red, angry cellulitis, the heat and pain and so on. Those symptoms can be suppressed by the steroid treatments that you're applying and the calcineurin inhibitors. So even though you don't see this, you must have a clinical suspicion for infection. Now, bacterial infection is common, Staphylococcus aureus. There are much higher numbers of bacteria count on the skin of patients with eczema, whether they're babies or not. Even as a colonizing, not an infecting organism, can cause flare-ups because the patient actually creates anti-staphylococcal antibodies and is actually allergic to those bacteria that are living happily on their skin without causing actual infection. So treatment with antibiotics, decontamination regimes are helpful to help difficult eczema in that situation. Now, other than bacteria, there are lots of other organisms. This young baby here has quite angry, flaky eczema, and particularly babies around the necks and mouths where there's a lot of moisture, because they're drooling and vomiting, for example, they can get colonized with a lot of yeasts and fungi. So be conscious that may also be going on. More importantly than not is this condition here, which you'll all be very familiar with, eczema herpeticum. We learn about it in medical school, and when you're in your pediatric training, it's the thing not to miss. You get these well demarcated, punched out lesions on the skin. Sometimes you might see blistering beforehand. It's painful, but be wary, not always the case if your patient has been applying lots and lots of topical steroids. So always have a high index of suspicion and treat. We use oral acyclovir when the child is systemically well and it's in a discrete area. However, if the child is in any way systemically unwell, or a sensitive area like the eye or ear, for example, is involved, we may need to go for systemic treatments straight away. Okay, so thank you all very much for your attention. We've really whizzed through this presentation quite quickly. If there are any questions at all, you can pop them on the chat now. We'll give you a few minutes.
At the moment, there aren't any questions on the chat.
Yeah, there's a slight lag between our presentation. Okay, so there appears to be no questions at the moment. So what we'll do is we will allow you to go and get yourselves a nice cup of tea, or use the loo if you must, for 10 minutes or so before we join back again at 4:20, if that's okay with you, or 3:20 for those of you on European time. Okay, so please, we'll leave the presentation now. EIP team, just checking we're not live anymore. Yeah.
Give me a sec. No, we are not going to stop the live, but you can close cameras and come back when you are ready. Is that okay? Perfect. Thanks.
20 past.
Hi, EIP team, we're back.
Yeah, whenever you're ready, you can start again.
Okay, so are we live again?
Yeah.
Okay, thank you very much, everyone. I hope you've got your cup of tea now and feeling more comfortable. Without further ado, I'm going to allow SOPHIA KALLIS to start her talk on dietary considerations in the management of eczema. Okay, SOPHIA.
Right, can everyone hear me okay?
Yes.
Yeah.
Perfect. So yes, I'm going to be talking about dietary considerations for the management of eczema. Let me try. I have no conflicts of interest to disclose. So there's a bit of a time lag with scrolling through. Here we go. So what I'll be covering in the next 15-20 minutes is when to consider dietary exclusions for the management of eczema and which foods to exclude and how to do that safely. After excluding, when do we reintroduce them and how do we go about doing that? And at the end, I will touch briefly on early introduction of food allergens and what the current guidelines are. So there's long been a debate as to which comes first. Does eczema cause food allergy or does food allergy cause eczema? And the dual allergen exposure hypothesis proposes that it's through cutaneous exposure where food particles can penetrate the skin through a broken skin barrier, as in the case of eczema. And it's that cutaneous exposure which drives an immune response and sensitizes the patient, causing allergy. In contrast, when there is oral exposure, so when a food is consumed and it passes through the gastrointestinal tract, it promotes tolerance. So there is a link between the two, a close link between the two. And there are many common symptoms of food allergy, eczema being just one of them. But really, if you're seeing moderate to severe eczema in a young infant under 6 months of age, that does tend to be quite a red flag to be considering food allergy as a cause. Other common symptoms are varied and can include gut symptoms such as diarrhea or constipation, nausea, vomiting, stomach pain, bloating or distension, excess wind or gas, blood and mucus in the stools, as well as skin reactions, so hives, swelling, as well as difficulty feeding, poor appetite, congestion, and even affecting the respiratory system. So there's lots of common symptoms we see in food allergy. But we must bear in mind that these symptoms are common in non-allergic children as well, in otherwise well children or those with other diagnoses. So the clinical history is so important here to make that judgment as to whether we think food allergy is relevant. Trial exclusion diets should only be considered if the history and the examination are strongly suggestive of food allergy. And if the infant is breastfed and the mother has to exclude foods from her diet, we really do take every measure to support the mother to continue breastfeeding if that's what she wants to do. If we focus on the skin side of allergic symptoms, we have our IgE-mediated allergy and non-IgE-mediated allergy. As we know, with IgE-mediated allergy, symptoms usually present within minutes of consuming food, whereas with non-IgE, it tends to be more delayed in the hours that follow or even in the days that follow. But as you can see, whether it's IgE or non-IgE, their skin can be affected in either. And with IgE, it's much easier to tease apart what the cause has been because usually you would eat the food and within minutes see symptoms developing. So it's easier to tease out the cause. With non-IgE, however, where there is more delayed presentation, it can be harder to go back and find out what was the offending food or allergen. So with non-IgE allergy, really the cornerstone for the diagnosis is the elimination diet. We don't have any approved tests for non-IgE mediated allergy, so our test is to eliminate the suspected food and then reintroduce it and see if the symptoms resolve on elimination and then reappear on reintroduction. And we would usually advise avoiding the food for 2 to 4 weeks before reintroduction. That could be either directly in the child's diet, or if the mother is breastfeeding, eliminating the food from the maternal diet. The most common allergens, so if we think about which foods are we considering, the most common allergens in children are cow's milk, egg, peanuts, tree nuts, fish, shellfish, wheat, and also soy, which isn't listed there, but is another common allergen. But when we're focusing on non-IgE allergy, the top 4, I would say, tend to be cow's milk, soya, egg, and wheat. And these are the ones that we tend to consider first for exclusions if there is severe eczema that we think is allergy driven. If we focus on milk exclusion, as that tends to be one of the most common and one of the first things we often exclude, we would avoid any foods that contain cow's milk protein. So that's not just milk itself, but also things like yogurt and cheese and butter and ghee and all the things listed here. Now, what about soya? In practice, we tend to exclude both cow's milk and soya together when it's a non-IgE mediated allergy due to the high cross-reactivity between non-IgE cow's milk allergy and soya allergy. So there's 60% crossover between the two. So in practice, we tend to exclude dairy and soya together for 2 to 4 weeks. And at the end of the elimination period, we would reintroduce them one at a time. If the infant is being formula fed, then we will ask the GP to prescribe a suitable extensively hydrolyzed formula. And these are just some of the options that we have available. They can either be casein-based or whey-based. We very, very rarely use amino acid formula as our first line option unless there is severe failure to thrive and a history of severe reactions, including anaphylaxis, which tends to be quite rare in young infants. So in most of our cases, we will opt for an extensively hydrolyzed formula. If it's an older child or if the mother is having to exclude dairy from her diet, there are now lots of alternatives available, not just soy milk, but also oat milk, coconut, almond, hemp, rice, and not just milks, but now you can get lots more options for dairy-free yogurts and cheeses and ice creams. So if a dietitian is involved, they can advise on what alternatives are available, and preferably alternatives which are fortified with calcium. Many of the milks are very well fortified with calcium, so that's quite useful to have in the diet. Nevertheless, unless they're taking large quantities of dairy-free alternatives, we have to consider the nutritional adequacy of the diet whilst they're avoiding dairy. So calcium and vitamin D tend to be important considerations and may need supplementing. If they're not taking enough fortified products, then we can advise on multivitamins. We've also been considering a lot more recently iodine intake. So we know that cow's milk, egg and fish are rich sources of iodine. So particularly for our multiply allergic children, if they're avoiding cow's milk and egg, and if they're also on top of that avoiding fish, then there's a real risk of iodine deficiency. And that may need supplementing also. Some of the dairy-free milks are now fortified with iodine as well, so they can be recommended where we think they are appropriate. There are lots of different supplements on the market for that can be bought over the counter. So for mothers, there's calcium and vitamin D or multivitamins. And for children, they come in different formulations as well. You can get liquid formulations or chewable sweetie type calcium, vitamin D softies. So whichever the child prefers and will take more easily. What's really important though is at the end of the 2 to 4 week elimination diet, the importance of reintroduction is always emphasized to our patients, because we don't want them avoiding foods unnecessarily, but also that's really how we can more confidently make our diagnosis. So even if the symptoms improve on the elimination diet, it's only really once you've reintroduced the food and seen a return or a worsening of symptoms that we can more confidently diagnose the non-IgE mediated allergy. We also have to consider the risk of converting from non-IgE to IgE-mediated allergy if the elimination diet is followed for a prolonged amount of time. And there have been reports of both children and adults who've avoided a food for extended periods of time, and where in the past their symptoms were all delayed or cutaneous in nature, and then upon reintroduction further down the line, their symptoms were IgE mediated, including even anaphylaxis. And there have been reports even of fatal anaphylaxis upon reintroduction. We don't know how long we can safely eliminate a food without that risk, but in practice we advise 2 to 4 weeks elimination. That should be enough time to see an improvement in symptoms before reintroducing and challenging that food again. How to reintroduce? Well, if it's after 2 to 4 weeks, if it's one food, you would just put it back in the diet and observe for the return or worsening of symptoms. If they're avoiding multiple foods as part of their elimination diet, then we would advise reintroducing one food at a time, allowing at least 3 days between the different types of food in case of delayed reactions. It doesn't tend to matter which order the foods are reintroduced, but I would usually say if the parent, for example, has a strong suspicion that one food in particular is more likely the cause, then we'll leave that one till the end. But they can choose which order they wish to reintroduce the foods back into the child's diet. And there are ladders, reintroduction ladders, available that we can use as a guide. But these are for non-IgE allergy only. If there is, if we know the child is sensitized on skin prick testing or specific IgE testing, we will often reintroduce the food under hospital premises, so as a food challenge in hospital. But for non-IgE, we have different ladders, and these are just the front covers of some of the leaflets we have available for egg, for soya, and for wheat. And the idea with each of these ladders, it's a step-by-step approach of reintroducing these foods, starting with small quantities that are well cooked, well processed, and as tolerated, you build up step by step to give more quantities of the food and less processed and cooked. So if we take the milk ladder as an example, this is the IMAP milk ladder, which if you Google it, you can find it online. And the idea with the milk ladder is that you start at the bottom. You would start at step 1 with something like a plain cookie or a biscuit that contains some cow's milk protein in it, in the form of milk powder or butter. If after 2-3 days the child is well and not shown any delayed symptoms, then you can move on to step 2, which would be something like a muffin or a plain cake that contains a little bit more cow's milk protein, but again has been baked in the oven. And as you progress through the steps, you're moving on to foods and dishes that contain a greater amount of cow's milk protein and are less processed, less cooked. So you would finally end with either fresh cow's milk or a cow's milk formula. That would be the last thing that you would try. And the idea with the milk ladder is that if the child develops symptoms at any point, you would stop at that step, wait for 3 to 6 months before trying that food again. But whatever has been tolerated up until that point, you would continue to give. You wouldn't want to go back to the bottom of the ladder. You would just continue to give what's been tolerated and wait to try the step that has caused symptoms a few months further down the line. I just wanted to touch on at the end whether early introduction of foods can prevent allergy from developing, because this has been publicized a lot in recent years and discussed a lot ever since the publication of big studies such as the LEAP study, which looked at the early introduction of peanut into young infants' diets, and the EAT study, which looked at the early introduction of multiple food allergens, including peanut, milk, egg, wheat, fish, and sesame. And they showed encouraging results. And so a large meta-analysis and systematic review by Ierodiaconou et al. Looked at the evidence and assessed that there was moderate certainty evidence that the early introduction of egg from 4 to 6 months of age was indeed associated with reduced egg allergy. And similarly for peanut, early introduction of peanut has moderate certainty evidence that it reduces peanut allergy. They found high certainty evidence that the timing of gluten introduction was not associated with celiac disease risk, so there's no reason to delay the introduction of wheat. And there was high certainty evidence that the timing of allergenic food introduction was not associated with other outcomes, including eczema. So it appears that whilst we may be able to modify development of egg allergy and peanut allergy to an extent, we cannot prevent the development of eczema. Following on from such large studies, our UK guidelines have now been updated. So the BSACI, the British Society for Allergy and Clinical Immunology, updated their guidelines in 2018 to reflect this. And they now recommend that if an infant has a known risk factor for allergy, i.e. if they have eczema, and or an existing food allergy, that you may wish to consider introducing cooked egg and peanut from 4 months of age. Whereas if they do not have any risk factors for food allergy, as in the general population, you would continue to introduce at around 6 months of age, but not before 4 months of age. So we now tend to follow this in clinic, and with our high-risk infants, we do try to encourage early introduction of cooked egg and peanut, unless there have been previous reactions or allergy testing that advises against that. So to conclude, the first thing really is the importance of an allergy-focused clinical history. That's what's needed to really assess the risk of food allergy before you would consider a trial elimination diet. And if you do advise on an elimination diet, ideally if you can offer some sort of dietetic support to ensure nutritional adequacy, both of the child and the mother if she's breastfeeding. And if needed, we may need to consider supplementation with calcium and vitamin D, and possibly iodine as well. Our elimination diets, we usually recommend to do it for 2 to 4 weeks to allow for symptoms to improve. But at the end of the 4 weeks, it's really important that the food is reintroduced back into the diet to confirm the diagnosis and to avoid any risk of nutritional inadequacy by following an elimination diet for too long. Thank you very much. Any questions on the chat?
I've got a question for you, Sophia.
Yes.
You know, in the reintroduction letter, like for example, the milk that you showed, and they've come up to level 5 and they couldn't proceed further to step 6 of the reintroduction. And the recommendation, you said that we don't pursue further with that, but continue giving all the others that they have passed so far. Is there a certain number of times the family should give to the child the food, or is it a weekly thing, or is it twice a week? They've got to continue giving so that their immune system tolerates it to build up.
Been tolerated. Yeah, whatever has been tolerated up until that point, we advise giving it regularly. I mean, there's no real guidelines on how regularly, but we do say at least 2 to 3 times a week if possible, just to make it part of their regular routine to give that food, whether that's a small biscuit every other day or something like that, just to keep that cow's milk protein in their system. But they can keep giving all those foods up until the point where they're showing symptoms, and that they would just need to avoid and keep retrying every few months to see, because cow's milk, non-IgE cow's milk allergy does tend to improve with age, so we want to keep testing and seeing how their tolerance is doing.
Yeah, so important. Yeah.
Thank you.
You have one question on why not appropriate for IgE allergies since immunotherapy sometimes is. That's really interesting. I mean, more recently there has been an IgE mediated ladder developed, so it's a much more kind of cautious approach to laddering the dairy back into the diet. The obvious risk is just that we can't predict the kind of reaction if there's an IgE mediated allergy, so we don't know how the child will react. So we'll obviously take into consideration what kind of reactions they've had in the past, if they have poorly controlled asthma. These more high-risk infants, we will be more keen to challenge them in hospital rather than at home. But as I say, there is now an IgE-mediated milk ladder, which is a more cautious approach rather than the non-IgE to use at home.
Yeah, and that's a really great question as well, because oral immunotherapy for food is certainly an up-and-coming area. I believe there was a talk earlier on in the course about this. It's still not very widely used in the NHS services here, and I'm not sure about other countries, but something that's certainly hopeful for the future, particularly regarding egg and milk allergies. Okay. Good. Any other questions from either the panel or the audience? Okay, so if not, we'll move on to Lakshmi's session, and we can always save up any questions you have for the panel at the end of, we'll have plenty of time at the end. So Lakshmi, if you'd like to start sharing your screen.
Mute. Okay. Hi everyone, my name is Lakshmi Singaram. I'm one of the pediatric asthma clinical nurse specialists at UCLH. In the next 15 minutes or so, I will take you all through the use of inhalers and nasal sprays in the management of asthma and allergic rhinitis. The key success to control symptoms brought about by any atopic conditions like eczema, rhinitis or asthma, the main thing is to avoid triggers, which was covered earlier by the other speakers like Dr. Salt, Penny, Dr. Salt, Dr. Go, and SOPHIA. However, there are triggers that we cannot avoid or families cannot avoid, things like dust, things like pollen, where we've got to think, okay, how is the family going to control this and these risk factors or these triggers? So with regards to damp, we do, advise hoovering and not sweeping, doing damp dusting, and other measures. And we also advise sometimes preempting and before getting in close to the trigger, things like if a cat is a trigger for their symptoms, then they can take antihistamine before, visiting or going near the cat. And we also emphasize a lot on adhering to their return management plan for all these atopic conditions, because that's a key to achieving good control. And also it's important for the patients and the family to recognize and respond to the symptoms and using the correct techniques while they're taking the treatment. And family also should know when to seek medical advice appropriately and not to delay it. Sorry about that. Atopic conditions, often the patients that we see in the clinic, they don't come just with single atopic condition. Like in the audit that we did recently from our asthma clinic, only 17% of them had just pure asthma. 30% of our patients that come to our clinic had asthma, allergy, rhinitis, and eczema. So it's really, really important when we see patients in clinic to address all the coexisting atopic conditions, because like, for example, when you treat rhinitis, you find that actually asthma control gets better. Also not to forget when we see patients in clinics to assess and address the unseen when we see the patients. Things like unrecognized risks. For example, a patient may come to the clinic and They can tell you, I don't smoke, or there's no one actually smoking, but on home assessment, you find actually you smell cigarette in the home environment. They may be demonstrating appropriate or correct inhaler technique in front of you, but they may not be doing it once they leave your clinic. They may say they may have a return management plan, but they actually lost it somewhere. And also to investigate further in terms of, you know, are they actually doing all what they should be doing for, you know, are they exercising, or are they stopping doing exercise because their asthma or rhinitis, you know, the breathing symptoms become a problem, so they are not actually exercising. Environment, you know, is there mold? Is there damp in the house? Is there overcrowding? Those things also can affect the atopic symptoms greatly. Also, it's good to investigate if the patient has got poorly controlled asthma. For example, are they using a lot of short-acting beta-2 agonists like salbutamol and not actually using the preventer inhaler? And here you've got to actually see what they believe, what treatment actually is working, because when actually exploring further with these patients and families, you'll find that the patients believe in salbutamol, which is just a reliever, and they don't believe in the preventer treatment because they don't see the symptoms going away after taking it. So it's really important to assess and address those things when you see them in clinic. Non-adherence is a big issue in any atopic conditions because it's not always there. It comes and goes in most of the atopic conditions, especially with asthma. So it's really important to address all of them. In the next few minutes, or in the next 10 minutes or so, I'll take you all through the use of inhalers and nasal sprays in managing rhinitis and asthma. The key thing when you think about your patient, what inhaler you're going to prescribe, first of all, you've got to see how old is the child and whether what inhaler you're going to give, does it come in the form which the child could take it on? So age, ability of the child to actually take the inhaler correctly, ability of the parents to actually administer for the child is another thing that also should be considered before the prescribing takes place. And also you got to think about, can this child use the device and the inhaler that you're prescribing in an acute situation? And will they use it when they're up and about among their friends? Because especially with teenagers, some of the devices, they will not use it because they are very self-conscious about what the friends will say about it. Inhalers and devices, there are many forms and shapes it comes, and in many strengths, and you've got combination inhalers, and you've got just a reliever and a preventer separately as well. So there's many that you've got to actually put the inhaler and the spaces together that fit to your patient and family, and they will use it. It's really, really important. And also in some countries, you got to think about cost, because they may have to, parents or the patient will have to buy these inhalers, and some of them are more expensive than the other. So if you're going to prescribe something that is expensive, the family is not going to buy it. So it's also important factor. And time I put there, because especially in children, young children and teenagers, they've got a lot more important things in life to do, and they will say taking inhaler is taking time, so I will take it later, and then they forget about it. So you got to think about, okay, what will work for that child. So there's a lot of thinking and planning before you actually do the prescribing for these patients. As I mentioned earlier, there are many forms of relievers. Comes as a metered dose inhaler. They come as dry powder device as well. And each of them have got further breakdown, which is not on my slide. There's millions out there. Preventers, again, the same thing. It's important for patients and family to know what each drug do and how they work on their airways. because if they don't have this understanding, they're not going to actually take the inhalers correctly. We don't recommend giving controllers on its own because often we find that patients believe in the controllers because it relieves their symptoms, whereas the preventers doesn't. But actually, in the long run, it's going to cause more damage to their airways just having a controller without a preventer and treating the inflammation of the airway. So we move on from just using relevant preventers on poorly controlled ones, we switch them to combination inhalers, and we also use them in the non-believers of the preventers, because by giving them the combination inhaler, we find that adherence is a lot better because they have the reliever and the preventer at the same time and saying, yes, it works. And actually we successfully get on board some preventers into their airways. So never to use the controllers on their own. After thinking about the inhaler that you want to prescribe, then you got to think about the spacer device. And again, these are just some spacer examples here, which we use at UCLH. There are many different makes and brands out in the market. It's important to know how they work and whether the child will be able to use it and whether the parents can manage to give it using this device to the child. There are key factors, because you can give a spacer to the child and the child may not use it or don't like to use it, or the parents are not able to administer it correctly. So when you see them in every clinic visit or in accident emergency department or inpatient stay, it's a key factor to check their technique every time to make sure they've got it right, which I'll do a demonstration later in a minute with some of the devices that we use at UCLH. It's common, it's still very common here, though we keep driving saying that metered dose inhalers has got to be taken via spacer. And with babies, when you put a spacer on their face, they cry. And often parents say, oh, they cry, so I'm not going to use a spacer because, you know, parents get stressed, the child gets stressed, medicines don't get delivered to where it needs to go. Crying, babies should not cry, young children should not cry when they have the spacer on. So the key to it is we ask the parents to actually get to play with the spacer with the child so they don't get frightened with the spacer going on the face. And even with adults, teenagers, adults, we recommend using a spacer because you get better drug delivery to your airways, and not, if you don't use a spacer like you see on the slide here, the inhaler, the medicine goes to the back of the throat, most of it gets swollen into your stomach and hardly any reaches your airways. If you take with a spacer, you get better drug delivery to the airways where it should go. Even the experts, it's difficult to coordinate when you activate your metered dose inhaler and actually breathing it all the way in. It's very, very tricky because the minute the cold spray hits the back of the throat, it's automatic response. We have the little pause. That's when it sticks to the back of your throat. Now I'm going to take you through some of the devices we have got here. I'm going to start with the nasal spray first. Again, with nasal sprays for rhinitis, there's many makes out in the market. The one I've got is the placebo of the Avamys, which you see here. Before any nasal spray, before the child takes their nasal spray, they got to prepare themselves. Like earlier, Dr. Go was saying, preparation is the key. Again, with nasal spray or spacers, preparation is the key. So get themselves, blow their nose if they're blocked with any snot, get their nasal spray, shake it first, and it's important to prime it. I'm not sure whether you can see it on the screen. You've got to get the fine mist, make sure it's not a little blob of water that's coming up, because if the little blob of water is what you get, when you put it into the nose and you spray it, the little blob is the one that irritates the nose and patients don't like it. So once you get a fine mist, it's ready to go. Then and you've already cleared your nostrils, you block one nostril. We call it the crisscross technique. And then you angle your neck like so you're reading a book. You pop your nostril into the opposite nostril and you spray. At the same time, you breathe in gently. The way you angle it, not to the middle septum, because that will irritate. Again, patients will not take it, and some of them get sore nostrils because of that. It's got to be to the fleshy part of your nostril, and so it covers your whole nasopharynx where medicine should go. So they breathe in gently, and then they can breathe out through the mouth. And you do the same to the opposite side. And often people don't like the nasal sprays because they're not using the right technique. It irritates your nose. It causes soreness, so they will not take it. And some of them, they don't, again, like the inhalers I said earlier, they need to know what's inside here. So nasal sprays, most of them have got some steroids. So they're like preventers. They've got to be taken regularly, not just when the nose is blocked like a reliever. It doesn't help bring the swelling down. So we got to educate the patients when we see them in clinic. Again, with Avamys, you've got like a little window here, which tells you whether how much medicine you've got in there. Then you can close it and put it away. Then moving on to spaces, you've got from spaces with the mask. This is a volumetric, it's got a mask. You can use it up to age of 6 months or so, where the mask will fit the child's nose and the mouth well. It does not fit an adult size or bigger teenagers. So if you see your teenagers coming to clinic and they say, this is what I use, then you've got to make sure you correct the right device, because they're not going to get the medicines, all the medicines they're taking their spacer. So, so that's for the mask. And you can also have this without the mask for bigger children. So you shake it before, put it in the spacer, you have a bite. We tend to use this after using a mask device before we're moving on to the mouthpiece device. We always tend to use a volumetric because it's got a click sound which parents can listen to see whether the child is actually breathing in and out through the mouth or not. It's tidal breathing. It's nice big breath, and you can hear the click. I'm not sure whether you all managed to hear the click or not, but the click is a good indicator for the parents to know that they're doing it correctly and not breathing in and out through the mouth, through the nose. And some of our, 1 or 2 of our teenagers still like the volumetric for that reason, because they find it's a lot easier. We do have air chamber spaces, which it comes from the yellow ones is for bigger children. For babies up to 6 months to, if you're ex-premature baby, you may be able to use the orange one of this up to about 9 months or so. The mask, air chamber spaces comes with a mask device as well as a mouthpiece, just on the mouthpiece. Again, they are quite good because you can shake the space of inhaler while it's in there, and you've got, parents have got an indicator here to see whether they're breathing in and out correctly or not. So I'm just going to show you. I'm not sure whether you can see it or not, but there's a valve that flaps. So it's quite good. Any inhalers that's given with the spacer with the mask device, we recommend parents count up to 10 seconds, because after 10 seconds, the medicine and whatever is there anyhow would have stuck at the sides of the spacer. And then for the next puff, you shake it and you spray it again and do the same thing, count up to 10. in babies and small children, you've got to make it as a friendly experience for them. So we tell parents, you can, instead of counting 1 to 10, you can even use any nursery rhymes that you think is probably, takes up to about 10 seconds, because they think that the parents are playing with them. So you get, and they don't cry, they don't push out. It's better on experience for the family, for the child as well. The arrow chamber of the mouthpiece has got no indicator of any sort. So unlike the volumetric, which has got a click. So how would one know whether the child is breathing in and out through the mouth or not? The only way is if you pinch the nose while they're doing, and you can see whether are they still comfortably breathing in and out. If you pinch the nose and they struggle and they have a gap, or they have gap in the side of the mouth, then you know they are actually not taking it correctly. There's no other way you can actually tell whether they are doing it correctly or not via this device. So it's really, really important. Another thing with this device is that when you spray and you take a big breath, it's normal tidal breathing and not one big breath sucking it in, where you hear the whistle. If you hear the whistle when you breathe in, basically there's a valve in here that shuts and you're not getting the medicine. I'm not sure whether you can see me. My video got stuck. Oh, here we go. That sound is incorrect. And again, we only recommend 1 spray at a time and not 2 at one go, because we have patients coming to the clinic and say, well, the doctors told them to take 4 puffs, and they demonstrate in clinic, they shake it and they do 1, 2, 3, 4, and then they breathe in and out. Actually, they're not getting anything much at all, because what happens is the mist bits get stuck together and they stick at the side of the space, that they're not getting the dose, the 4 puffs. So it's 1 puff at a time and they breathe in and out. The mouthpiece device, we recommend breathe in and out 5 times. And then moving on, if a teenager who doesn't want to use a spacer because it's time consuming, or they feel shy to use in front of their mates, it defeats the purpose, because they may be wheezing when they're playing sports and they don't want to use their spacer. They're not going to get the medicine. So they may say, oh, I sit out and I rest for a bit, then I start playing. It's not going to help, because again, they will start to wheeze and they can't continue playing. So then we got to think about dry powder devices. There are many dry powder devices out in the market. Once we use at UCLH, it's called the EcuHaler or the Turbohaler. Again, it all depends. They come at different strength, different combinations. You've got relievers on its own, you've got preventers on its own, you've got combination inhalers of different strengths. Then we've got to tailor it to meet to what the child or the young person needs and what they will use. So we often test to make sure whether they can use the device correctly before we prescribe, because no point prescribing something that doesn't work because they will not take it, or they're not taking it correctly. So we test the technique with the placebo devices we've got. So the way you do it, I'm not sure if you saw it. So you open it, then you push the lever down, you get 1 dose, not 2, 1 dose. You breathe out first, and then put your lips around here and make sure your teeth is not closed, because if your teeth is closed, then the medicine will stick to the teeth and not go to your airway. Hold for 10 seconds and then you breathe out. For the second dose, again, you close it, you open it, and you do it again. Another thing that you can see in some kids, if you ask them, how do you take your 2 puffs of your preventer inhaler? They come to the clinic and I've seen them doing 1, 2. I've got 2 puffs and I'm taking it. Actually, they're getting 1 dose, because what's inside here is a disc that rotates. So you're not getting 2 doses, you're only getting 1. It's little things that really, if you pick it up in your clinic appointment, it'll help actually get the child's asthma controlled better, because they probably didn't get the right education when it was prescribed and given to them. Very important. So that's dry powder device. And we've got another one is turbohaler. Turbohaler is the one that you click and you hear, once you hear twisted anti-clockwise and clockwise, you hear the click, you got one dose again. And then you do the same thing, you breathe out, then you put this, have a good seal with your lips, and you breathe in. Count for 10 seconds and then breathe out. If you want the next one, you do. I've again come across patients doing, if 2 puffs, they do it twice and say 2 puffs done and go down. It's important with the EcoHaler device, you've got a digital counter which counts down. Yeah, it counts down. With the turbohaler, some of it you get a digital counter, like relievers don't have a digital counter. We've come across patients where they think there is still medicine in here in their reliever, but actually they run out of it. There's a slight differentiation only in they've got 2 lines instead of a digital number. So it's very easy to think they have got it, because what they do is they shake their device and they can hear the noise. What the noise is basically is a desiccant inside here to keep the powder in a powder form, not the actual medicine. So with dry powder devices, we recommend not to put in the shower where it's steaming and it'll cake up. It'll tend to cake up, even though they've got desiccant. So we recommend best to keep it outside the shower room, next to the bed or somewhere where they remember to take it when they, in the first thing in the morning and in the evening before bed. So those are the devices we tend to use. We stress a lot on technique when we see patients, and we also stress about adherence. Now, adherence can be a big issue, especially as the kids grow bigger. As in teenagers, they wake up late, they go to bed late, their timing is all over the place, or they're running late for school because they've been up all night watching something on their phone. So we got to tailor something that will work with that person. So we sometimes even, there are patients that we say, take it first thing when you brush your teeth and take it at dinner time, because before bed, when they watch all their whatever they need to watch or do before their bedtime, they get tired and fall asleep without taking the preventer inhaler. So we tell them to take it with the dinner time, because that way we can ensure that they actually have a preventer inhaler and not miss the dose. So it's really, education is a key factor, and also to buy in atopic condition, the key thing is we got to build a partnership with the family and the child to make it all work. And they have to actually agree and believe that it will work. Otherwise, it won't. Now, I lost my share screen. Let's get back to that. Here we go. So I've covered on these spaces and things. Adrenaline auto injectors, which we use more for allergic reactions. I will still touch on it just a bit, though this talk is more of eczema and rhinitis. How to use an adrenaline auto injector? Again, we have got 3 brands that we tend to use at UCLH. We've got EpiPen, we've got Emirate, and we've got Jex. Now, it can be very confusing for anyone if, let's say, if we, family has been very used to EpiPen and then they run out of stock or something, and then the pharmacists give them an Emirate or a Jext, or the GP prescribed. So for whatever reason, so it's really, really important when we teach patients technique, some of the key important things is pretty much a similar thing. So what I'm going to do is I'm going to show you EpiPen. You take it out from the case, take off the blue cap at the back, hold it with the dominant hand, and you don't actually have to take off the child's clothes or anything. It's the middle outer aspect of the tie, and you jab from about 10 centimeters away and hold it. Now, EpiPen currently is the company is telling us you only need to hold it for 3 seconds. Then you take it off and you rub it, and then you call 999 for ambulance service to take you to a hospital. Now, it can be very confusing for families, because what we've seen our clinics is they said, oh, the last time they told us hold for 10 seconds, Emirate tells them hold them for 5 seconds, and Jax tells them for 10 seconds. So it can be very, very confusing. So what we tell them is, as long as you hold it for 10 seconds, doesn't matter. It's no harm done. It's important to remember they're all lay people, and they need to have something clear in their head when you give them different pens. And my screen has stopped working. Just a minute. Just trying to get that working again.
Don't worry, Lakshmi. Actually, it's great when we can see your video the best, actually. So we're just going to get them to pin your video.
Yeah, I'm coming back to that one.
Brilliant.
Okay.
You're back on video now, Lakshmi.
Can you see me?
Yeah.
You can see me? Yeah? Okay. So it's really important to know what your child, what your patient and parents are doing with the medicines that you've prescribed for them, and you review them for follow-up clinics. Don't assume, the key is don't assume they are taking what you ask them to take correctly. Always check. Because there are many times they don't do what you tell them to do. And make sure when they leave your clinic, they go away with the written management plan, which they can actually refer to in emergencies or when they forget. And we recommend patients and parents take a photo shot of the plan, because they don't leave their phone behind, whereas paper copies always get mislaid or lost. So it's one of the, we find that it's very useful, because parents can actually refer straight to the phone, or the teenager can look at the phone to see what they should be doing when they get the symptoms. I think I have run through the nasal spray, the inhaler devices, and touched on adrenaline auto-injectors in management of atopic conditions like rhinitis and allergies, and also asthma. Is there any questions? Anyone got any questions?
No questions just of yet, but I've got a few questions for you, Lakshmi. So, you know, adherence, yeah, it seems to be a real theme here. And I understand there are special ways that they monitor this in like the tertiary services. That even when a child actually ends up getting referred quite high up the ladder, if you like, in terms of the referral ladder, that actually compliance is often still very much an issue, isn't it?
It is. It's because most of the time we find issues are big in families where they've got large families, where they are, you know, as it is, they, you know, financially may be struggling. They may be living in a damp, moldy house where there's got a lot of other priorities, and parents struggle to make sure to remember to give the child the inhalers, or they find it very stressed. For example, if you've got a child with asthma, eczema, rhinitis, you know, you've got so many treatments to do. It's like round the clock, and it's so stressful on top of that. So to them, it's like, what do? I have to make sure I go out and earn money, otherwise they won't get food. And I'm trying my best. So it can, in those kind of families is where we find that got really bad eczema patients, patients with bad eczema, poorly controlled asthma, where the parents don't have the time to actually put into the child's care, even though they try their best. So we try to work out something that will work for that family. That's the key factor, because we can't change some of the things because it's beyond what we can do, but we've got to work something that will work for them, or even try to find, is there anyone else in the family members could help support in administering this treatment, or if they're living in some of the families live with their extended family, maybe they could help in. So yeah, it's
no, it's a really tough situation. Penny, maybe this one's for you. Are you aware of any sort of new devices, in terms of allergen elimination, environmental allergen elimination to help improve that situation for, like dust mite coverings, air purifiers? Are you aware of anything that you would recommend your patients, or anything on the horizon?
Well, so house dust mite avoidance is tricky. And there are lots of products on the market, but whether anything works particularly well. I think some studies have shown that mattress protectors to reduce house dust mite may help. And there's some basic strategies limiting soft furnishings in the home, using some of the methods that Lakshmi spoke about, using damp dusting and vacuuming as opposed to sweeping and dry dusting. There are some more novel treatments, so laminar flow, which is basically looks like a hairdryer that goes over a patient's bed, and it basically just drops cool air over the patient, and it helps to move the house dust mite out of the way, and that's shown to be successful in asthma. And there is actually now a multi-center study looking at whether it's effective in those patients with eczema who are sensitized to house dust mite. Some of them, also to go back to what you were asking about tertiary centers having ways of monitoring whether patients are taking their inhalers or not. There are smart meters which actually have little microchips in them, and they can actually record when a dose has been administered. It doesn't actually tell you if the patient's administering it correctly using a spacer device, but it does tell you when they are discharging the device. And so after you've given a patient this device to use for a period of time, you can download that information and see what times they're taking the dose, how often they're taking the dose, which is helpful to see sometimes where they might be struggling to give the dose, or periods where they haven't given the dose, and to go back and to find out from the patient what was actually happening at that time. Other strategies also help is there are newer steroid inhalers and combination inhalers that are single daily doses, like Relvar, which can sometimes be helpful in chaotic families or in teenagers where they're struggling to remember to take their medications because it's once a day. In some situations, schools can also be brought in to help. So just like with TB therapy, where you might have directly observed therapy, you get the school involved, and it's actually the teacher that's giving that once a day dose. And that way that can often help with adherence and giving medications.
Yeah,
Community nurses can also be helpful, can do visits at homes, especially things like with eczema management, and helping with seeing how families are managing at home, and going and actually doing the wet wrapping in extreme cases as well.
There are some studies as well they're doing on video observed therapies for adherence, where, because like what Penny was saying, activating the smart inhaler doesn't mean that they're actually taking it. So they are testing out whether the video observed therapy is a way, will it make any difference in terms of whether it's a child taking it correctly with the right technique for inhalers.
So Sophia, it's a particularly bad combination, isn't it? If a child has asthma and IgE-mediated food allergies, what particular advice do you give as a dietitian to these families? When when there's that combination?
Well, it's depending on their previous reactions and the type of allergy that they have. There's always a risk if they have poorly controlled asthma and IgE allergy. They are at higher risk of anaphylaxis type reactions. So it's just being super cautious with the diet, you know, really kind of explaining food labeling, understanding where the risks lie when they're having to avoid foods. And these are the kinds of children that, when we are considering reintroductions, we will more often than not do them in hospital rather than at home to mitigate any risks.
Any other questions from the panel?
I was going to ask actually, because a common question I get from lots of parents is because we do see that combination of eczema and food allergy together, and lots of parents will get in contact and say they've tried a new food and the child has had an eczema flare days later, and they always think it's because of the food that they've introduced. Is there a cutoff point in terms of timing after which you'd say it's unlikely to be the food and probably something else that's flaring the eczema?
That's a really good question, and sometimes it's easier than other times. That's you know, in the situation where perhaps it's only an hour or two after eating where you get the delayed response, and particularly things that are a little bit more obvious, like vomiting, for example, as opposed to more subtle, like changes in the eczema, which can be under the child's clothes and then not noticed for some time. The you know, technically a delayed or non-IgE mediated reaction can be as delayed as 4 or 5 days, although mostly it is within a day or two. And this is where it brings to the importance. It's really hard to look retrospectively when there has been a reaction. That's the worst way to confirm a food allergy, actually, to look back and say the child has had a reaction. Even in IgE-mediated food allergy, the pre-test probability of a child who's had, for example, one immediate reaction to egg is 30%. Actually, of having a genuine egg allergy. Now that goes up with number of reactions, so 60% if there's been 2 history of reactions, and into the 90s if there's been 3 consistent IgE mediated allergy reactions. Now, delayed or non-IgE mediated allergy, we really have to boil back down to conscious elimination and reintroduction sequences, which are planned. And they often have to be repeated because babies teethe or they get viral infections, and it's really hard to tease out where these non-specific symptoms of maybe some tummy ache, diarrhea, or eczema flares, which could be due to a number of different reasons apart from their food allergy.
Mm-hmm.
Penny, do you have any questions?
No, I think we've actually probably answered the ones that we've brought up in the panel. So far, there haven't been any further questions on the chat.
Good. So we're ending ever so slightly early today, which gives you an extra 5 minutes break before your next session. I think sometimes these online sessions can be pretty hard going, so enjoy your extra 5 minutes, and thank you for joining us today in this new type of online workshop. It's new for us too. We look forward to hearing any feedback you may have to make it better in the future. Thank you very much.